During this episode of Banner Health's Making the Round podcast, we'll be exploring the world of pediatric orthopedic surgery, from treating complex fractures and limb deformities to innovative solutions for congenital disorders and neuromuscular conditions. We'll discuss the latest surgical advancements, the importance of early diagnosis, and how collaborative care between pediatricians and orthopedic specialists leads to better outcomes for our young patients. To learn more about these topics and other pediatric orthopedic services at Banner Health, please visit bannerhealth.com/pediatrics. Making the Rounds dives into medical topics with those who know them best, healthcare providers. My name is Bridget, and I'll be your host for today's episode. If you're new to our podcast, thank you for tuning in. And if you're a regular listener, welcome back. With me today is Dr. Ahmed Elabd, a pediatric orthopedic surgeon at Banner University Medicine Tucson and assistant professor of orthopedics at the University of Arizona College of Medicine. Dr. Elabd specializes in treating complex pediatric musculoskeletal conditions, including fractures, hip disorders, limb deformities, congenital abnormalities, and more. Thank you, Dr. Elabd, for joining us on Making the Rounds.
Thanks for having me here.
Well, we're really excited to have you today, and we are super excited to have you join our team here at Banner University Medicine. We have not had a pediatric orthopedic surgeon in quite some time, so welcome to Banner.
Thank you so much. It's very humbling to be here among all these surgeons and help treating the kids that really needs help around the area here.
Well, wonderful. Dr. Elabd, can you start by telling us a little bit about your background and what brought you to Southern Arizona?
I'm originally from Egypt. I graduated my medical school in Egypt, did my residency of orthopedics over there, and then came here to the United States to first explore the research options. So I was able to start doing some research between Texas Tech University and Texas Children's at Houston. And that's what drove me to, I want to be in the system to practice, to be able to help patients over here. And then I went back to Egypt. I started my first fellowship, which was highly specialized fellowship focused on pediatric orthopedic oncology, so treating only kids with bone tumors. And then I moved here and started my journey of extensive training in the Northeast area. First fellowship was orthopedic oncology, including adults and pediatrics at MedStar Washington Hospital Center. That's with Georgetown University. It was really good training. The second one was my fellowship at pediatrics at Montefiore Medical Center, Albert Einstein in New York. And then my third fellowship was at Children's National in Washington, D.C. When you have extensive training and work with a lot of surgeons, so you kind of collect these experiences from everyone, and that's really becomes handy and really helpful when you start practicing.
Oh, that's fascinating. Well, we are definitely lucky to have you here
at
Banner University Medicine and here in Southern Arizona. What gaps in pediatric orthopedic services have you seen in this region, and what are you and your team doing to fill those needs?
I didn't see much gaps here, but I think that the number of the patients much more exceed the number of physicians that do pediatric orthopedic surgery over here. So here there is a lot of schools, and the population has a lot of kids that really would need, musculoskeletal conditions, like, care at some point. The area has, I think, 2 or 3 pediatric orthopedic surgeons, and then the kids have to wait for a while to get that appointment, sometimes a month, sometimes a couple of months. So I think the best thing about me being here is trying to get these kids to the care earlier. In terms of technical, I would say I didn't see much of limb deformity correction or limb lengthening since I started here. So that's maybe something I can help me and my team to, get this better over time and start that service and build it over time to help kids rather than they have to drive for 2-3 hours to receive their care.
Pediatric fractures and trauma care range from simple breaks to complex injuries, and sometimes those can involve the growth plates. Dr. Elabd, what should pediatricians in the community know about the advanced fracture care that you have to offer here?
I'd say that, here we can offer treatment for any kind of fractures that involve pediatric population at, regardless the complexity. So definitely there will be very straightforward fractures that just needs cast or splint and they will do well, and you will see these more complex fractures that involve the growth plate. Definitely it's harder fractures to heal, and we have to counsel the family about, like, even after that fracture heals, sometimes there are some growth disturbances that we would follow the kid until their skeletal maturity and make sure they don't have that growth disturbances, and in case it arises, we will deal with it in different ways. So I think we are here with all the resources we have. We will be able to take care of fractures in kids up to 18 or 20 years of age. The most important part in this world is not exactly treating the fracture right now. It's following the kid until their skeletal maturity to make sure that they don't have deformities, especially with the lower limb deformity, like lower limb fractures like distal femur fractures, or those that really involve the lower limb, because they really affect their leg length, they affect the alignment of the lower extremity, and that really affect their function and mobility. We should be able to take care of these as they come to our ED.
Hip disorders can be particularly challenging in children. Can you walk us through some of the complex hip conditions that you treat, like developmental dysplasia, and how can pediatricians identify when it's time to refer to you?
DDH, or developmental dysplasia of the hip, is definitely common. You see it now and then. It's always discovered very early, like after they're born. There are certain tests that done for every kid that was born called Barlow and Ortolani test, when you see if these hips are really stable, if you can dislocate them, if there is any kind of dysplasia. So the examination is the first thing to detect these disorders of the hip. And then comes a different part when if the examination is normal and this patient has risk factors. Most of the risk factors that included in this disease is breech presentation and positive family history. So by the American Academy of Pediatrics, they recommend to have ultrasound of the hips at 6 weeks, even if this patient exam is normal. There is different ways how we treat this, starting from the Pavlik harness, which couple of straps that keep them in position that the hip reduces, and over time it's nicely contained. Different other braces, the rigid abduction braces, and if those failed, we have to go forward with the surgery, which first include closed reduction, without making an incision, and seeing if we can get good reduction for these hips. And ultimately, if all that approach has failed, we move forward to open surgery. When we open the hip, put it back, and make sure it's stable in position, and have them in a cast for a while. And again, follow them almost to skeletal maturity to make sure that they are developing nicely. There is no issues with their growth. The follow-up is really valuable until they're skeletally mature, and you make sure that they are doing well with that.
This is usually something that's diagnosed at a 6-week follow-up. What is the pediatrician looking for during that exam?
Every pediatrician, when they see the patient, they were just born for the first visit, they do a hip exam. They do exactly a hip exam called Barlow and Ortolani test, and that tells them if there is any abnormality. The other thing is like looking at the leg length difference. So if you flex the kid's legs and you see one is like longer than the other, that tells you that one of the hips may be dislocated, or there is any other abnormalities. I think every pediatrician knows the cutoff for these and when to be concerned to refer to the pediatric orthopedics.
So as you were sharing earlier, one of the services that you provide to Southern Arizona and in your practice is treating the limb deformities and limb lengthening procedures. Can you share more about some of these examples of the conditions that you see and treat in your practice? And what does that treatment journey really look like for a child that's undergoing some of these complex procedures?
Yeah, that's one of my passions in pediatric orthopedics is deformity correction and limb lengthening. You'd see a lot of these patients in their adolescent because of leg-limb discrepancy, so one leg is shorter than the other, and that happens because a lot of reasons. Sometimes it's trauma. We already talked about these fractures that involve the growth plate, and then sometimes after that the others stop growing or start developing like angular deformity. So you would see this patient with leg-limb discrepancy due to trauma, due to infection in the joint, infection in the bone, that their growth plate stopped growing and they're now developing either, angular deformity, varus or valgus, or developing leg-limb discrepancy. And then after assessment of the leg length, and we in the world of deformity correction, we see bones are as lines, and then these lines, there are certain angles that we measure to know where is the deformity coming from. Every case is different, so if the kid has only leg-limb discrepancy, we can do limb lengthening to the shorter side, and that can be done in certain ways. With all the technology advancement, we can do it now with precise nail, which is an intramedullary nail that we put inside the bone. So we cut the bone first, put that nail, and that nail expands over time with an external remote control. So we put that nail in, and then the patient is able to, they have instructions how to use that remote control, and every day they grow and the bone forms. It's called distraction osteogenesis. And then we can actually, I would say, we can lengthen with this procedure about 6-7 centimeters. Deformity correction is different. We have to correct the angles. So we have, distal femur that in valgus, so we have to go in and make an osteotomy, cut the femur, correct it to the position, and then fix that with blade or nail based on what we can find. Another kind of deformity that we see and we treat is the rotational deformity. So you would see some kids that walks with their feet completely in or sometimes completely out, but the intoeing is much more common. For this, we have an assessment called CT rotational profile when we look at the angles of how much this bone is twisted. And then based on these numbers, we would discuss with the patient if this is something they want to pursue to do the surgery, is to unwind the bone. So again, same principle, you go and you cut the bone and you turn it to where you think it is the right position, and then fix it with a nail or a blade. That's also another type of deformities that we treat over here.
And depending on what the condition is when when these interventions start?
Yes, that's correct. So you can start doing leg lengthening starting from 8 years of old, but you can also people have done it earlier, 4 years.
Dr. Elabd, as you had mentioned earlier, the care for these children undergoing orthopedic surgery is a journey. And your care philosophy really emphasizes that collaboration with the family and those other providers that are involved in that patient's journey. How can pediatricians work with you to ensure that the children are receiving seamless, coordinated orthopedic care here?
For now, we're able to see the patient at least same week. So if they have any referrals for us, it's the same week. I can see them the same week and take care of them. The other thing also I encourage the pediatrician in my talks to do is to reach out to me if they have questions. So it does not have necessary to be referring the patient, but you get this x-ray and you're not sure about what you can see and if this patient needs to be referred. I would say I try to follow up with pediatricians, so because I know the pediatrician will see the patients more frequently and more regularly than I do. So even if I have a patient that I did surgery for, so I would reach out to the pediatrician saying, hey, this is what we're gonna watch out for the next 6 months and I need to see him in a year. bone health is one of the things that pediatricians really do a great job with that, and I really applaud them for that, making sure that everybody has good vitamin D, levels of calcium are good, and everything in terms of bone health is good. So I think that communication is really, really valuable, to be always on the same page with the pediatrician that's really seeing the patient more regularly and more frequently, and they can identify things much more than I do, because I see them for a short period. Like if they have a fracture and once they are healed, I don't see them again. But the pediatrician is the cornerstone of that whole process.
Oh, that's wonderful, Dr. Elabd. And I know that the community, the pediatricians and the parents really appreciate that communication and that cross collaboration.
That's right. And I think the other thing also I probably identified since I started here, there is some kind of gap in communication between the the providers and the family. I see family a lot, that they have seen already a doctor or two, but they did not get the answers they want. They did not get the answers that they're looking for. So I think communication is one of the most important things, especially with the family. Like, as a father, I have kids, and I know if one of my kids are sick, I go to the doctor with all these questions, and I care about them more I care about myself, right? You want them to be better. You want them to be able to do what they want to do, right? So I see that family comes with a lot of questions, and sometimes just answering these questions get everything ready.
You're treating the patient, not just the symptom.
Yes, you should. That's correct, and that's the gap I've seen. Like, you should have your encounter in pediatric orthopedics should have two parts. Part is talking to the family, and part is talking to the kid and exploring what they think. And you would be amazed how much these kids can tell you, and how much just talking to them and telling them, we're here for you, and this is what we're gonna accomplish, how much they will be able to help you to get to that goal.
What else excites you about the future of pediatric orthopedic surgery here at Banner University Medicine?
The leadership here has been super helpful in solving any problem I face. So if I have any issues in the OR, any issues in the clinic, I have a lot of help starting from Dr. Alfar, who's our chief, and our administrative team, and even other surgeons is really helpful, the OR, the clinic nurses, the clinic team. Resources also has been great here. So since I started here, every implant I ask it for, it's available from different vendors, some kind of bone grafts, some kind of, different technology that was not used here. So they always do a great job, getting this to me before surgery. And then implant-wise, we talked about that. Also, even like intraoperative support, if I need something, if I need to create a new protocol for something, for people are helpful and willing to adopt new things.
Well, we are so grateful for you, and I can't thank you enough for you sharing your amazing insights and care that you provide here for our pediatric community.
Thank you so much for having me.
Thank you again for joining us in this conversation around pediatric orthopedic surgery. If you found this conversation as informative as we did, please subscribe to our podcast for more discussions on important medical topics. To learn more about pediatric specialty services available at Banner University Medicine Tucson, please visit bannerhealth.com/pediatrics. Thank you for listening, and we'll see you next time on Making the Rounds.